highlight the top 3 abstracts in the Utilization and Coverage track here at the North American CF Conference. My name is Ryan Perkins, and I am a combined pediatric and adult pulmonary fellow at Boston Children's Hospital and Brigham and Women's Hospital. I, along with my colleague, Dr. Dave Young, a professor of pharmacotherapy at the University of Utah, will serve as your co-chairs for this workshop. Today, we have 3 excellent abstracts to showcase. Our presenters will have 10 minutes to present their work. This will be followed by 5 minutes for questions and discussion by the audience. Just a quick housekeeping note before we get started. On the right-hand side of the screen, you will see a text box with separate tabs for chat and question and answer. We encourage you to chat socially throughout the presentation in the chat tab, but please submit questions in the Q&A tab. Only questions entered into the Q&A section will reach the speakers and moderators for consideration. Without further ado, let's get started. Our first presenter today is Andrew Neesmith. Andrew is a 4th-year medical student at the University of Alabama, Birmingham. He will be presenting his abstract entitled Multi-Center Assessment of Telehealth Experience of Care in Adult People with Cystic Fibrosis. Andrew, take it away.
Thank you for that introduction, Ryan. I'm going to get my screen shared momentarily. Okay. Like he said, the title of my project is the Multi-Center Assessment of Telehealth Experience of Care in Adult People with Cystic Fibrosis. I'm honored to have worked with this great group of people and other centers to begin exploring telehealth care in cystic fibrosis during the COVID-19 pandemic. I have no disclosures. We were initially interested in this topic as part of a project based on the following. Telehealth offers a unique platform for healthcare delivery. It's not been widely integrated into the adult cystic fibrosis care model. There are advantages to telehealth, such as improving access to care, eliminating travel times, and minimizing risk of infection. COVID-19 pandemic necessitated rapid implementation of telehealth by CF centers in order to monitor health and maintain optimal health during the pandemic. When we were composing this study, we identified these objectives. Characterize adult people with CF attitudes toward integrating telehealth into their usual chronic care. Assess convenience of the visit. Determine if there is concern with the absence of usual in-person assessments, such as pulmonary function testing, weight measurement, sputum and throat culture, and vital signs and physical exam, as well as desired role of telehealth in future care. This study is part of a larger research project that also characterizes pediatric telehealth experience of care and clinician telehealth attitude and experience. Those abstracts were done by Jacqueline Davis and Ryan Perkins of Boston Children's. To begin to answer these research questions, our group advanced the following methodology to answer these questions. We formed a multi-center working group that met regularly via Zoom to develop an online-based survey to assess attitude. Patient partners were involved in the survey development. The survey focused on 3 themes to assess telehealth experience: understanding the structure of and satisfaction with the visit, determine patient attitude about the lack of usual assessments, and the desired role of telehealth in their future care. We utilize 5 Likert scales to determine level of concern, where 1 is low concern and 5 is very concerning, and Likert scales for convenience and satisfaction, where 1 is low satisfaction or convenience and 5 is high satisfaction or convenience. Participating centers represented a broad swath of CF centers across the eastern United States, and patients represented the usual distribution of patients from these centers. You can see the centers listed in the table to the right. We were very pleased with the response of this survey, with 120 respondents with an estimated 20% response rate. As you can see, the prior telehealth visit was quite low for this patient population, with 72% indicating they had never used telehealth in previous times. And on the right, you can see difficulty accessing telehealth visits, and patients indicated they did not have any difficulty accessing their visits. So in summary, though most had not used telehealth previously, few reported difficulty accessing their visit. We also sought to get a sense of what disciplines were interacting with patients, given the multidisciplinary nature of typical visits for CF patients. The distribution of disciplines that patients saw during their visit was comparable to an in-person visit, where they would see a physician most times, followed by an advanced practice provider, and dietitian, nutritionist, and registered nurses. We were happy to observe that approaching 80% viewed telehealth visits as highly satisfying from a patient perspective. In addition, they found visits overwhelmingly convenient. You can see in this figure that most patients either responded moderately, high convenience and satisfaction, or high convenience and satisfaction. And again, the Likert scale we used. Despite the global excitement with telehealth from patients, we wanted to see if patients felt these visits met the usual multidisciplinary visit they are accustomed to. Patients indicated in an overwhelming majority they were able to see the desired disciplines they wished to and felt all issues and concerns were addressed. In addition, they strongly agreed they had adequate time to spend with each discipline. Regarding lack of pulmonary function test and throat sputum culture, patients had at least moderate concern approaching 50%. Unlike vital signs and physical exam and weight measurement, where the concern was much lower. Our final question to patients was determining how often they would like telehealth integrated into their chronic care. And over 90% preferred at least some visits in the future to be conducted over telehealth. In addition, patients responded with strong interest in home pulmonary function assessment to go along with their future telehealth visits. So, our study described experience of patients with cystic fibrosis participating in telehealth care at their respective CF centers. Of those people surveyed, most reported a positive experience. Patients were mainly concerned with lack of PFTs and sputum/throat cultures. This is being mitigated by home pulmonary function assessment as well as mail-in sputum kits. The strengths of our study: we surveyed an array of patients across multiple CF centers. An estimated 20% survey response rate was noted, and recall bias was limited by issuing surveys within 1 week of the patient's first telehealth visit. The limitations of our study: perceptions could be affected by the COVID-19 pandemic. Patients could be responding positively just because they are able to actually have a clinic visit during a pandemic, as well as there could be possible response bias due to lack of random sampling. So conclusions: patients are willing to engage in telehealth care. Patients express that telehealth is viable in the cystic fibrosis chronic care model going forward. More research will be needed after the COVID-19 pandemic to assess long-term attitudes. Studies assessing adult and pediatric patients with CF and clinician perceptions about telehealth are ongoing. This data suggests that telehealth could be integrated into routine follow-up care in the CF chronic care model. Finally, future patient family experience care surveys will have integration of some of these survey methods and questions. We are very happy that this group has already authored several manuscripts which have been submitted. Acknowledgements: first and foremost, I would like to thank the patients of our study for their participation. I'd like to thank my mentor, Dr. Marty Solomon, as well as collaborators on this study, and all of the staff at the participating centers. Thank you for letting me present.
All right, Andrew, thank you for that very interesting presentation. At this time, I'd like to open the floor up for questions. And just as a reminder, if you do have a question, please put them in the Q&A section of the box in order for us to be able to send them on to the presenter. And while we're waiting for questions, Andrew, I'll ask you one of mine. The survey data that you collected and compiled identified concerns amongst patients regarding the lack of PFT and then throat and sputum culture sampling at visits. When you were evaluating your data, did you notice that there were differences in concerns from patients who answered the survey early on compared to those who answered it towards the end of your survey period?
So I think throughout our survey, we kind of saw a pretty similar distribution of response for concern. Initially, the data was a little bit more where they were less concerned with the lack of things, but as time went on, it kind of got back to that middle of 50% being more concerned and 50% having lower concern.
Are there any plans currently for follow-up studies to assess the durability of answers amongst our patients over time and as they become more comfortable and familiar with telehealth?
Yes, currently we have a pediatric study ongoing that's assessing hybrid survey visits where part of their visit is done in the actual in-person clinic and the other half is done by telehealth. So we're assessing that currently. And I think we have plans to issue another survey in the future to see if attitudes have changed over time, but that's oncoming.
All right. And the survey work that you did currently, these were all done utilizing pure telehealth visits. Uh, what role do you think that hybrid visits will be able to play in the future, moving forward to addressing some of these concerns that were elucidated from the study?
So hybrid visits naturally give the opportunity to have patients do a pulmonary function test and do a sputum test while they're in the clinic. So that mitigates those risks, and they don't have to have the technology at home if they can't get it, and they don't have to worry about mailing in any type of throat or sputum culture. So the hybrid visit kind of gives us the best of both worlds in that way.
All right. Andrew, thank you again for that very interesting presentation. Our next presenter today will be Dr. Eric Walter. Dr. Walter is an adult pulmonologist and critical care physician at Northwest Permanente in Portland, Oregon. Dr. Walter will be presenting his abstract entitled "The Effect of Elexacaftor, Tezacaftor, Ivacaftor on Hospital Days and Cost, a Single Center Experience." Dr. Walter, please take it away.
Hi, good morning, good afternoon, Dr. Perkins. Thanks for that introduction. My name is Eric Walter. I'm an adult pulmonologist at the Kaiser Permanente Cystic Fibrosis Clinic in Portland, Oregon. Today, I'm going to be talking about the effect of elexacaftor, tezacaftor, ivacaftor, or triple therapy as I'll refer to it during this talk, on hospital days and costs, a single center experience. I do need to disclose that I get a small amount of salary support from PCORI, or the Patient-Centered Outcomes Research Institute, the National Institutes of Health, and the Cystic Fibrosis Foundation. I don't think that any of the support will affect the bias in this talk. So as background, we all know that triple therapy was approved in 2019 for patients 12 and older with one copy of Delta F508. We also know that it's very expensive. In our center, it costs $317,000 per year. After we started prescribing triple therapy, we noticed pretty quickly that hospitalizations appeared to be decreasing after patients started triple therapy. And we were hearing this from other centers as well. We wanted to quantify this, so we decided to compare hospitalizations before and after initiation of triple therapy. So as part of a quality improvement project, we performed a retrospective review of all patients who started triple therapy at our center. Patients not on triple therapy were excluded. We compared days hospitalized for CF-related diagnoses from January 1st through August 31st, before and after beginning triple therapy. For pre-triple therapy years, we looked back as far as 2016. We then stratified our results by severity of lung disease, and we estimated hospital costs and potential savings. So here are our results. We're a small center, so we had 47 patients eligible for triple therapy. 32 patients had started triple therapy as of August 31st, 2020. And you can see down at the bottom that the most common reasons for not starting triple therapy were patient choice. This was usually people that felt that they were healthy, and ivacaftor monotherapy. The mean age was almost 32 years, and most of our patients, or just over half, were female. 12 patients, or 38%, had severe lung disease, and we define this as an FEV1 less than 40% at any time during the study period. In our center, the average or the median start date for triple therapy was February 11th. This figure shows the average number of days per month patients were hospitalized for CF-related diagnoses before and after starting triple therapy. So for example, in 2016, you can see that we had an average of 39 patient days per month that patients were hospitalized. That means that we had patients in the hospital a total of 39 days. So that could have been one patient hospitalized for 3 days or 3 patients in the hospital for 1 day. Most of those hospital days were in patients that had severe lung disease. That makes sense. In the case of 2016, it was 29 patient days per month and 10 patients per month on patients that did not have severe lung disease. Over time, the average number of patient days per month was relatively stable from 2016 through 2019. And even into the beginning of 2020, we averaged 27 patient days per month. As I mentioned earlier, the average start date was February 11th, 2020. And after starting triple therapy, we didn't have any patients hospitalized that were on therapy at all. Now, this figure shows through August 31st. The slides were put together before the end of September. I can say that we also had no patients hospitalized through the end of September. And in fact, the first hospitalization we had of a patient on triple therapy was about 2 weeks ago. This figure shows the cumulative 2020 monthly hospital cost savings following the initiation of triple therapy. These numbers were estimated by using the average hospital cost at our system of $6,700 per day and multiplying it by the average number of hospital days per month. For the entire cohort, we estimate a savings of about $190,000, and the bulk of that savings were in the smaller cohort of patients with severe lung disease. And since hospitalizations through the end of August had been 0 since starting triple therapy, these costs represent monthly cost savings. Another word about costs. I mentioned before that our hospital cost savings were estimated to be $189,000, but the medication is still it's still quite expensive, and it costs about $845,000 per month to provide this medication for this cohort. So it represents still a significant cost expenditure. In patients with severe lung disease, hospital cost savings offset medication costs by nearly 50%. And this is because the bulk of patients hospitalized were in those patients with severe lung disease, and they're a smaller group. So in conclusion, before beginning triple therapy, the cumulative number of days hospitalized per month was approximately 28 days per month. Following triple therapy, we didn't have any patients hospitalized through the end of August, and in fact, our first patient was hospitalized just 2 weeks ago. The estimated 2020 hospital cost savings since starting triple therapy was about $189,000 per month. Some strengths of this study: we are a small center with a small cohort in a closed system. Because of this, we were able to identify all hospitalizations over the prior 5 years, and we have known hospital costs. We do have excellent pharmacy support that allows us to track triple therapy start and adherence quite well. Some limitations. The biggest limitation is obviously the fact that this reduction in hospital days coincided with the SARS-CoV-2 outbreak, and this did likely affect hospitalization rates. I mentioned this as a strength, but a limitation is also that we're a small center in a closed system, and so our results may not be applicable to other centers. So where do we go from here? The next step, we would like to compare total IV antibiotic exposure before and after triple therapy. Our center uses home IV antibiotics frequently. When we get our annual CF registry report, we are often well below the mean number of days for hospitalization in patients that are being treated for exacerbations. I will let you know that anecdotally, we have seen less IV antibiotic use, just like we have seen less hospitalizations. But quantifying this may help us address the potential decrease in hospitalizations that were due to the SARS-CoV-2 outbreak. Because we did have patients that called in, told us they were sick, needed to be treated for an exacerbation, but didn't want to go to the hospital. In closing, I need to thank the Northwest Permanente the Kaiser Permanente Northwest Cystic Fibrosis Clinic. We've got a fantastic team, and I definitely couldn't have done this without their help and support, and our CF patients and families. I'd like to thank you all for your time, and I'm happy to try to address any questions that you may have.
All right, Dr. Walter, thank you again for that very interesting presentation. While we're awaiting questions to come in, I'll go ahead and ask you one of mine. I think it's amazing that there were no hospitalizations during the particular time, and I think you're right that COVID probably factors into that in some fashion. That being said, did you guys track outpatient clinic visits or oral antibiotic utilization during that same period of time?
We haven't done that yet. Outpatient utilization, just like all centers, dropped off dramatically as we switched to telehealth. It was, I think, easier for us to switch to telehealth because we had a pretty robust telehealth program already in place. We have not looked at oral antibiotics. That's much more difficult to compare pre and post because patients will be prescribed oral antibiotics and then not necessarily take them. That's why we're going to focus on IV antibiotics in the next step of the study.
I think Kaiser is a very interesting center to be able to look at cost in that they're both a provider source and a payer source. When you guys were looking at cost information, did you look at charges that were billed by the center, or did you actually look at insurance claims that were generated by the payer side of Kaiser?
We didn't look at either of those because it's a closed system that is less applicable to our system. And so in order to estimate costs, we use the average hospital day cost in our system.
All right. Well, looking to see, are there any questions? All right, Dr. Walter, thank you again for that very interesting presentation.
Thank you.
All right, and moving on to our final speaker of the session today, we'll have Dr. Kimberly Dickinson. Dr. Dickinson is a pediatric pulmonary fellow at Johns Hopkins University in Baltimore, Maryland. She's currently funded by the Cystic Fibrosis Foundation, and she'll be presenting her abstract today entitled Socioeconomic Status Effects on Adherence Barriers to Chronic Therapies for Management of Cystic Fibrosis. Dr. Dickinson, please take it away.
Okay, can you hear me now? So thank you for that introduction and the opportunity to present our work at today's workshop. My name is Kimberly Dickinson. I'm a third-year pediatric pulmonary fellow at Johns Hopkins. My interests relate to exploring how non-genetic factors such as socioeconomic status impact outcomes in CF. In this particular study, we wanted to assess the effects of socioeconomic status on adherence to chronic pulmonary therapies. I have no relationships to disclose. So we all know that adherence to treatments and therapies is associated with improved health outcomes in CF, but we also know that treatment regimens are complex and time-consuming and that poor adherence is common, with studies suggesting adherence rates of less than 50% for chronic pulmonary medications. To understand what limits adherence, it's important to assess what barriers people with CF perceive as getting in the way of doing their treatments. In other chronic disorders, financial barriers or lower socioeconomic status is associated with non-adherence, but this relationship has not been well established in cystic fibrosis. So understanding people with CF's adherence barriers and if they differ by SES is important for developing tailored interventions to support sustained adherence. To identify different barriers to adherence as well as their contribution to non-adherence, the Success with Therapies Research Consortium created the Daily Care Check-in, or the DCC. It's a validated 18-item measure that assesses the most common patient-reported barriers to treatment adherence. Participants indicate yes or no whether they experienced the barriers in the 6 months prior to the check-in, and it also assesses the degree of interference of the barrier. As you can see, there are a range of barriers that people with CF report. However, the focus of our study was evaluating the relationship between socioeconomic status as measured by insurance status and household income and medication adherence, as well as adherence barriers. Our study was a cross-sectional and observational study conducted at 21 USCF centers, both pediatric and adult centers participating in the Success with Therapies Research Consortium. There were very few exclusion criteria because the goal was to have an inclusive and representative sample. To be included in the study, you needed to be at least 13 years of age with a confirmed diagnosis of CF and prescribed at least one chronic pulmonary medication. You also needed to sign a release of all of your refill information. We know there's no perfect measurement of socioeconomic status. In CF literature, insurance status is often used to approximate a person's socioeconomic status because it's more readily available in the registry than annual household income. But for our study, we looked at both insurance status, self-reported insurance status and self-reported annual household income. Insurance status was dichotomized into private or military insurance or insurance that's provided through your employer and compared that to those with public or no insurance. And then we broke down annual household income into 3 income brackets. To measure adherence, we retrospectively looked at 1 year of pharmacy refill records. Medication possession ratios were calculated for each prescribed therapy. Medication possession ratios calculates the number of times a medication was refilled over the number of times that medication was prescribed and helps to provide a more objective measure of medication adherence. These values were then averaged and a composite medication possession ratio was calculated for an overall score. Here are the demographics of the 376 people included in our study. 2/3 of the sample had private or military insurance, and that did not differ by adolescents or adults. Overall, the 3 groups were evenly distributed by household income. As might be expected, the adult group had lower income due to the fact that our overall study population was younger. The average age was under 30, so most were young adults early in their careers and no longer living with their parents. Overall, the study population reported close to 7 barriers, where those adolescents reported closer to 6 and the 18 and older group reported closer to 8. Our hypotheses for the study were that those with lower SES would report overall more barriers. We thought they'd be more likely to report financial or insurance issues getting in the way with doing their therapies, and we thought they'd have lower adherence to chronic therapies. So we broke down our results by the 2 measures of SES. Listed in this table is the total number of barriers endorsed, people's medication adherence, and then the individual daily care check-in items that had significant differences between the 2 insurance groups. If you'd like to see reporting of the other barriers, we'd encourage you to go look at poster 794 in the virtual poster hall. So as we can see, the public insurance group reported more barriers than the private insurance group, but this difference was not statistically significant. We can see there was poor adherence in both groups, though the lower SES group did have lower adherence, but again, this was not statistically significant. As we thought, those with lower SES reported more trouble paying for their treatments, food, or things they needed to take care of their CF. Notably, there was no statistically significant difference in reporting that insurance interfered with doing their therapies, suggesting that insurance issues affect individuals with CF regardless of insurance coverage. We also noted that individuals with lower SES were more likely to report symptoms of depression or anxiety interfering with their ability to do their therapies. Unlike insurance status, the total number of barriers had a statistically significant association with annual household income. As you can see in this group as well, medication adherence was poor in all groups, even in the highest income bracket, but those living with the lowest income reported more barriers and had overall lower medication adherence. Again, when we looked at having trouble for paying for your treatments, those with lower SES were more likely to report this as a barrier, but notably even the 40 to 100,000 group were more likely to report financial challenges. And again, we see that those with lower SES were more likely to report symptoms of depression or anxiety interfering with their ability to do their therapies. These analyses were repeated by age group and essentially found the same results. There were a few limitations to the study. It was a national sample, but it only included people who attended a clinic visit. People with lower socioeconomic status or potentially higher barriers may be more likely to attend a clinic visit and therefore may be underrepresented in the study. And people may have been uncomfortable disclosing adherence barriers. However, we attempted to minimize this with computerized surveys and reassuring individuals that their providers would not know what they reported as being their barriers. So what we took away from this study is that adherence barriers and suboptimal adherence are common regardless of how we measure SES. Lower household income was statistically significantly associated with more adherence barriers and lower medication adherence. While the pattern was true for public or no insurance, it was not statistically significant. While barriers did not statistically differ by SES, lower SES was associated with a higher reporting of anxiety and depression symptoms compared to those with higher SES, which we thought was a notable finding from our study and highlights the importance of screening for mental health comorbidities that may impact non-adherence. Routine screening is essential to identifying financial and broader adherence barriers, including mental health comorbidities. The daily care check-in facilitates discussions about barriers and helps individuals to identify their own barriers. But it is important to note that not everyone with public insurance or in the lower annual household income bracket report the same barriers, and that having several different barriers to adherence is common. Additionally, both insurance status and annual household income can change from year to year, and this can lead to changes in people's perceived barriers and their overall adherence rates. It's important to routinely screen, but our results also emphasize the importance of the availability of supports for individuals, particularly those with lower household incomes who may report more barriers to adherence. Assessing the specific challenges that individuals with lower SES face, including financial barriers, is essential to understand how we can address their unique combinations of adherence barriers. I'd like to end by thanking the original participants in the Barriers to Adherence Screener study. I'd like to thank the Cystic Fibrosis Foundation for their continued financial support. I'd like to thank Dr. Reichert for her mentorship and all of our co-collaborators on our abstract. I'll wrap up there and happy to answer any questions.
All right, Dr. Dickinson, thank you for that very interesting and thought-provoking presentation. We do have a couple of questions that have come through on Slido for you. The first is, what age is the daily care check-in validated to, and is it readily available for clinical use?
13, it was only studied in individuals 13 and older, so individuals who'd be able to fill out the screener themselves is the ideal point of the screener. I believe it will be clinically available soon, but I'm not sure if it's quite yet. The Cystic Fibrosis Foundation is helping distribute it, but I'm not sure if it's clinically available quite yet.
All right. And our next question focuses more about how insurance is entered into the registry. Do you know, if a family has both private insurance and bridge public insurance, how is that coded into the registry?
They would be listed as having private and public insurance. And so that can vary by state, whether a family qualifies for public insurance, again, based off of having a chronic medical condition, but they would be listed as having both in the registry.
And our next question, do you feel that we are currently reaching these communities, or do we need to adapt our outreach differently?
Yeah, I think especially for I think what struck us was the mental health concerns, and is it that we are not sort of assessing for them appropriately, or is insurance potentially not covering the services that people might need? And so I think really, asking these questions to people or letting them, fill out a screener that can sometimes feel a little bit more anonymous and be more willing to disclose things, I do think is important, and that people are wanting to talk about these things, but may not be bringing them up. And so that we as providers need to be checking in with them.
Okay, our next question, what can care teams do right now to help families of low socioeconomic status?
Yeah, I think that's a great question. I do think anecdotally from other research that I'm doing is that people do want their teams to be asking, that people often whether there's some, emotion related to it, or some people feel embarrassed to bring these things up, that people feel that it is a place for their providers, especially, their CF providers, to be asking if there's any barriers, whether it's financial, housing, transportation, food, that their families may not be bringing those up in a clinic visit. And if we're not asking and screening for it, then we're not going to, I do think that people would be willing to talk about it if we were asking the question. So I think asking and screening.
All right. And the final question from the group: have any qualitative interviews ever been conducted to understand the experience of being poor and having CF? This may highlight more about what is actually going on and how we can design future interventions. Yeah, it's also a great question. And that's exactly what my research interest is what about socioeconomic status is leading to these poor, we know it's associated with poor health outcomes, and it may not be the same reasons for everyone, but what about having public insurance or a lower household income makes these situations more challenging for people to manage their disease and may lead to higher incidence of poor health outcomes. So I do think that that's a very important area of research. And the final question I see, did you look at FEV1 in these socioeconomic levels? It wasn't the focus of our study to be measuring those kind of outcomes and how they differed by SES, but there wasn't in our group statistically significant differences, I don't believe. All right, Dr. Dickinson, thank you again for this wonderful presentation and for those answers. We were having a slight technical difficulty with seeing some of the questions to the community earlier. So I'd like to bring back Andrew Neesmith just to answer a few other questions that have populated from the group. So Andrew, if you're around, do you think family satisfaction with telehealth was a function of the necessity due to COVID, or do you think it will remain highly valued as a sustainable model for the future?
So I think that this question can be answered with yes to both of these. Patients were satisfied with telehealth during the COVID-19 pandemic because they were able to have a clinic visit. With COVID-19, we didn't know if we could bring patients back to clinic or when that would ever occur. So they were very satisfied to be able to be seen via virtually. And I also think that it will remain highly valued as a sustainable model in the future, because now that we see how easy this technology is to use to assess patients' exacerbation, or just to check in with them without them having to actually come to clinic, is something that I think we will continue to use in the future.
And do you know what percentage of patients refuse to do telehealth and only want it to be seen in person?
So there were a number of people, at least from the UAB Center, but we didn't track that necessarily to get a specific percentage of patients that refuse telehealth.
Another question, from the center perspective, were telehealth visits conducted fairly standard for patients, or was there variability in the manner in which telehealth was being performed within those centers?
So each center kind of had a protocol that they followed, whether it was synchronous visits where each discipline all saw the patient at the same time, or asynchronous where each discipline saw the patient individually. And even within clinics, within centers, that varied as well, because of the nature of trying to reach someone over the phone or via Zoom, that it's somewhat difficult to get in contact with people, that you have to say, well, I will just meet them when I can, and it just ends up being whatever's good for the patient. So it was quite variable within the centers participating and within the actual centers.
And then finally, looking at the different disciplines that participated in visits, there was a question about why was there a low participation? Were providers more thorough, or what would you hypothesize is the reason for that lower participation?
Is low participation from pharmacy? Is that what you said you went out? Maybe freezing, but the low participation from pharmacy noted in our data, we're unsure exactly why that occurred, because the patient kind of was able to indicate who they wanted to see during their clinic visit. And at least from the UAB team, the pharmacy had seen the patient earlier in the year because we had tried to conduct as many as we could of our annual visits. earlier in the year. But I think that patient preference is really something that came down to why probably the pharmacy visits were lower.
I think Ryan may be having technical difficulties. He's probably trying to log back in. I'm his co-moderator. Another question for you, Dr. Naismith, is the CF Care centers have done a fantastic job in providing patients telehealth options. Are there other telehealth needs beyond the CF clinic for the CF community? Basically, kind of what are the next steps to that you can think of to better help our families virtually?
So this is a very interesting question, and I think it offers us the opportunity to have a discussion of how we want to give patients opportunities to interact with other patients or other cystic fibrosis family members, so they could have a network where they interact over Zoom or over any other platform that's available. And I think that that would be something we could utilize to increase the support system, because the cystic fibrosis support system is very strong. And if we can do anything to strengthen it during these times where it's very difficult to get together in person, I think we should definitely use the technology available to make that sort of thing happen.
And I think this is a question for Dr. Walter on the patient that was admitted. Was it associated with patient adherence?
Thanks for that question. It was not. This was essentially a failure of IV outpatient antibiotics. So she had been on a few or several different courses of IV antibiotics over a several-month period of time. And so she was admitted, actually admitted and underwent bronchoscopy. An organism that we weren't aware of was identified, and her treatment was then focused that way.
And there was also a question on the where do we find the daily care check-in tool?
Hi. Yeah, that I will have to speak with my other collaborator. I believe if it's not already available, it will be available soon, but I know people would be interested in having that, so I'll make sure to get back on that because I'm not sure.
And we got another one for you, Dr. Dickinson. Why do you think the NPR rates were so low across the board, even those with higher family incomes?
I think what our study really shows is that the rates of non-adherence are higher than we might think as providers. I think we found even for modulator therapy and these chronic therapies that we assume people are doing, or we're asking them to do, some of these therapies even several times a day, or do inhaled antibiotics, that the adherence is lower than we realize. And so I think finding out how we can address the barriers that people are experiencing that lead to these low adherence rates is is so important.
Thank you for that. There's another question regarding, are there programs to help families with no insurance? And then had said something about confirmatory testing.
I would assume those programs probably vary by state or maybe by center. So I would assume that would be the case, especially for our adolescent and pediatric population. I'm not exactly as familiar with what services would be available for adults who don't have health insurance, but definitely for children, I would assume that they'd be under some form of coverage.
Yeah, and I guess, speaking on medication access, that's what I do. I work with, I'm an adult center pharmacist at the University of Utah here, and with patients with no insurance, it can be a challenge, obviously, to get access to all the appropriate medications. The companies have individual programs, states have individual programs. So really, there's not, I don't think, one singular answer to that question. At least from that perspective, it's you have to take each individual case and kind of work through and problem solve on a case-by-case basis.
Okay. And breaking news, I just heard that a toolkit is in development to be available to different centers, but is not yet available. Sorry to answer up that first question.
And I'll turn the time back over to Ryan. There was a question about abstract numbers accompanying these posters, but I believe if you search under the utilization and coverage abstracts, you'll see that these abstracts have the stars on them. Plus, you can search by author and find the abstract and then the subsequent poster. And I'll turn the time back over to Ryan.
All right. Are there any additional questions from the group? All right. Thank you, everyone, again for your excellent work and for these excellent presentations. Also, thank you, everyone, for joining us today. I hope you enjoy the rest of the conference.
Thank you.